Good morning, my friends. I am Dr. Armen, Professor Armen Astvatsatryan from Yerevan, Armenia, and this is Dr. Y. And today we will talk about bronchiectasis. So bronchiectasis is a dilation and destruction of larger bronchi caused by chronic infection and inflammation. Common causes are cystic fibrosis, immune defects, and recurrent infections, though some cases seem to be idiopathic. So unknown reason, unknown cause, idiopathic. Symptoms are chronic cough and purulent sputum, expectoration, and some patients may also have fever and dyspnea. Diagnosis is based on history and imaging, usually involving high-resolution computed tomography, though standard chest X-ray may be diagnostic. Treatment and prevention of acute exacerbations are with bronchodilators, clearance of secretions, antibiotics, to management of complications such as hemoptysis and further lung damage due to resistant or opportunistic infections. Treatment of underlying disorders is important whenever possible, and not only in bronchiectasis, of course, in any diseases. About etiology of bronchiectasis. Bronchiectasis is best considered the common endpoint of various disorders that cause chronic airway inflammation. So bronchiectasis may be diffuse, affecting many areas of the lungs, focal, appearing in only one or two lungs. Lung areas. Focal, appearing in only one or two lung areas. Diffuse bronchiectasis develops most often in patients with genetic, immunologic, or anatomic defects that affect the airways. In developed countries, the cause of many cases appears initially to be idiopathic, so unknown reason, idiopathic, probably partly because onset is so slow that the triggering problem is not readily evident at the time bronchiectasis is recognized. So the triggering problem of the bronchiectasis is not readily evident at the time bronchiectasis is recognized. With newer, improved genetic and immunologic testing, an increasing number of reports describe finding and an etiology in these idiopathic cases are careful systematic evaluation. Idiopathic cases are careful and systemic evaluation. So cystic fibrosis is commonly associated with the condition. Previously cystic fibrosis, yeah. So cystic fibrosis is commonly associated with this condition, and previously undiagnosed cystic fibrosis may account for up to 20% of idiopathic cases. Even heterozygous patients who typically have no clinical manifestations of cystic fibrosis may have an increased risk of bronchiectasis. Immunodeficiencies, such as a common variable immunodeficiency, may also lead to diffuse disease, as many rare abnormalities in airway structure. Undernutrition and human immunodeficiency virus infection also appear to increase the risk. Undernutrition and human immunodeficiency virus, HIV. Congenital defects in mucociliary clearance, in mucociliary clearance, such as primary ciliary dyskinesia. So ciliary dyskinesia syndromes may also be a cause, explaining almost 3% of previously idiopathic cases. Diffuse bronchiectasis sometimes complicates common autoimmune disorders such as rheumatoid arthritis or Sjögren syndrome, and can occur in the setting of hematologic malignancy, organ transplant, or due to immune compromise associated with treatment in these conditions. Bronchiectasis can also be related to more common conditions including chronic obstructive pulmonary disease, asthma, or chronic recurrent aspiration, asthma. Allergic bronchopulmonary aspergillosis, so a hypersensitivity reaction to Aspergillus species that occurs most commonly in people with asthma, but sometimes in patients with cystic fibrosis can contribute to bronchiectasis. Aspergillosis, acute bronchopulmonary aspergillosis. In developing countries, most cases are probably caused by tuberculosis, particularly in patients with impaired immune function due to undernutrition or human immunodeficiency virus infection. Focal bronchiectasis typically develops as a result of untreated pneumonia or obstruction. For example, due to foreign bodies, tumors, post-surgical changes, lymphadenopathy. Mycobacteria, tuberculosis or no tuberculosis, can both cause focal bronchiectasis and colonize the lungs of patients with bronchiectasis due to other disorders. So, pathophysiology of bronchiectasis. The pathophysiology of bronchiectasis is not fully understood, likely in part because it's a common endpoint of heterogeneous group of disorders predisposing to chronic airway inflammation. The most widely accepted model described a vicious cycle, circulus vitiosus, vicious cycle of inflammation, airway destruction, abnormal mucus clearance, and infection of colonization by bacteria. Diffuse bronchiectasis occurs when a causative disorder triggers inflammation of small and medium-sized airways, releasing inflammatory mediators from intraluminal neutrophils, and the inflammatory mediators destroy elastin, cartilage, and muscle in larger airways, resulting in irreversible bronchodilation, so remodeling of bronchi. Simultaneously, the inflamed small and medium-sized airways, macrophages, so macrophages and lymphocytes form infiltrates that thicken mucosal walls. This thickening causes the airway obstruction frequently noted during pulmonary function testing. With disease progression, inflammation spreads beyond the airways, causing fibrosis of the surrounding lung parenchyma. Parenchyma. What inflammes the small airways depends on the etiology of bronchiectasis. Common contributors include impaired airway clearance due to production of thick, viscous mucus in cystic fibrosis, lack of ciliary motility in primary ciliary dyskinesia, or damage to the cilia and or airways secondary to infection or injury, and impaired host defenses. These factors predispose patients to chronic infection and inflammation. In the case of immune deficiency, autoimmune inflammation may also contribute. So focal bronchiectasis usually occurs when a large airway becomes obstructed. The resulting inability to clear secretions leads to a cycle of infection, inflammation, and airway wall damage. The right middle lobe is involved most often because its bronchus is small and angulated and the lymph nodes is in close proximity. Lymphadenopathy due to mycobacterial infections sometimes causes bronchial obstruction and focal bronchiectasis. As ongoing inflammation changes airway anatomy, pathogenic bacteria, sometimes including mycobacteria, colonize the airways. Common organisms include Haemophilus influenzae, Moraxella catarrhalis, Pseudomonas aeruginosa, Staphylococcus aureus, Streptococcus pneumonia, mixed flora, non-tuberculosis, mycobacteria. Staphylococcus aureus colonization is strongly associated with cystic fibrosis. A culture finding of Streptococcus aureus should raise concern for undiagnosed cystic fibrosis. Staphylococcus aureus, undiagnosed cystic fibrosis. Also, colonization with Pseudomonas aeruginosa tends to indicate severe disease and predicts worse outcomes, including increased risk of exacerbations, hospitalization, poor quality of life, rapid decline in lung function, and death. Colonization by multiple organisms is common, and antibiotic resistance is a concern in patients who require frequent courses of antibiotics for treatment of exacerbations. So complications. As the disease progresses, chronic inflammation and hypoxemia cause neovascularization of the bronchial, not the pulmonary arteries. Bronchial, not the pulmonary. Bronchial artery walls rupture easily, leading to hemoptysis, which can be massive and life-threatening. Other vascular complications include pulmonary hypertension due to vasoconstriction, arteritis, and sometimes shunt from bronchial to pulmonary vessels. Colonization with multi-drug resistant organisms can lead to chronic, low-grade airway inflammation. This disinflammation can progress, causing recurrent exacerbations and worsen airflow limitation on pulmonary function tests. So symptoms and signs of bronchiectasis. Symptoms characteristically begin insidiously and gradually worsen over years, accompanied by episodes of acute exacerbation. The most common presenting symptom in chronic cough that produce thick, tenacious, often purulent sputum. Dyspnea and wheezing are common, and pleuritic chest pain can develop. In advanced cases, hypoxemia and right-sided heart failure due to pulmonary hypertension may increase dyspnea. Hemoptysis, which can be massive, occurs due to airway neovascularization. Acute exacerbations are common and frequently result from a new or worsened infection. Exacerbations are marked by worsening cough and increases in dyspnea and the volume of purulence of sputum. Low-grade fever and constitutional symptoms, for example fatigue, malaise, may also be present. Halitosis, and abnormal breath sounds include crackles, rhonchi, and wheezing are typical physical examination findings. Digital clubbing is uncommon but may be present. Chronic rhinosinusitis and nasal polyps may be present, particularly in patients with cystic fibrosis or primary ciliary dyskinesia. Lean body mass commonly decreases, possibly due to inflammation and cytokine excess, and in patients with cystic fibrosis, malabsorption. So what about the diagnosis of bronchiectasis? History and physical examination, chest X-ray, high-resolution chest computed tomography, pulmonary function, test for baseline evaluation and monitoring disease progression, sputum culture for bacteria and mycobacteria to determine colonizing organisms, specific tests for suspected causes. Diagnosis is based on history, physical examination, and radiologic testing, beginning with a chest X-ray. Chronic bronchitis. Bronchitis may mimic bronchiectasis clinically, but bronchiectasis is distinguished by increased purulence and volume of daily sputum and by dilated airways shown on imaging studies. All the people. Imaging, so chest X-ray is usually abnormal and maybe, imaging. I can't show? Okay. So chest X-ray is usually abnormal and may be diagnostic. X-ray findings suggestive of bronchiectasis involve thickening of the airway walls and or airway dilation. Typically, findings include ill-defined linear peripheral densities with indistinctness of the central pulmonary arteries, indistinct rings due to thickened airway seen to cross-section parallel to the X-ray beam, and tram lines or tramline signs caused by thickened dilated airways perpendicular to the X-ray beam. Dilated airways filled with mucous plaques can also cause scattered elongated tubular opacities. Radiographic patterns may differ depending on the underlying disease. Bronchiectasis due to cystic fibrosis develops predominantly in the upper lobes, whereas bronchiectasis due to an endobronchial obstruction causes more focal X-ray abnormalities. High-resolution computed tomography is the test of choice for defining the existence of bronchiectasis, and it's very sensitive and specific. Typical computed tomography findings include airway dilation, in which the inner lumen of two or more airways exceeded the diameter of the adjacent artery, and the signet ring sign, in which a thickened, dilated airway appears adjacent to a smaller artery in transaxial view. Lack of normal bronchial tapering scan can result in visible medium-sized bronchi extending almost to the pleura. Tram lines are easily visible on computed tomography. As airway damage increases over time, bronchiectasis progresses from cylindrical to varicose. So from cylindrical to varicose, and then cystic findings or imaging. Atelectasis, consolidation, mucous plaques, and decreased vasculature are non-specific findings. In the traction bronchiectasis, pulmonary fibrosis pulse or distorts airways in ways that simulate bronchiectasis on imaging. Pulmonary functioning tests can be helpful for documenting baseline function and for monitoring disease progression. Bronchiectasis causes airflow limitation, reduced forced expiratory volume in 1 second, and FEV1, which reduces in the FEV1 FVC ratio. The FEV1 may improve in response to beta-agonist bronchodilators. In more advanced cases, progressive fibrosis may result in decreases in forced vital capacity. evidence of restrictive defect of lung volume measurements and a decreased diffusing capacity for carbon monoxide. So, diagnostic of cause. During an exacerbation-free period, all patients should have expectorated or induced sputum cultured to determine the predominant colonizing bacteria and their sensitivities. This information helps with antibiotic selection during exacerbations. A complete blood count and differential can help determine the severity of disease activity and identify eosinophilia, which may suggest complicating diagnose. Staining and cultures of sputum for bacterial, mycobacterial avium complex and Mycobacteria tuberculosis, and fungal Aspergillus species organisms may also help identify the cause of chronic airway inflammation, Aspergillus. Clinically significant non-tuberculosis mycobacterial infection is diagnosed by finding high colony counts of these mycobacteria in cultures from serial sputum samples or from bronchoalveolar lavage fluid in patients who have granulomas on biopsy or concurrent radiologic evidence of disease. When the cause of bronchiectasis is unclear, additional testing based on the history and imaging findings may be done. Tests may include the following: alpha-1 antitrypsin, alpha-1 antitrypsin level to evaluate for alpha-1 antitrypsin deficiency in high-resolution computed tomography shows lower lobe emphysema. Rheumatoid factor, antinuclear antibody, and antineutrophil cytoplasmic antibody testing if an autoimmune disorder is being considered. Serum immunoglobulins and serum electrophoresis to diagnose common variable immunodeficiency. Serum immunoglobulin E and Aspergillus precipitans if patients have eosinophilia to rule out allergic bronchopulmonary aspergillosis. Measurements of specific antibody levels against the capsular polysaccharide of Streptococcus pneumoniae to aid in the diagnosis of various immunodeficiencies. Sweet chloride tests. A positive test should be confirmed with repeat test. CFTR gene mutation analysis to diagnose cystic fibrosis, including in adults more than 40 years without an identifiable cause of bronchiectasis, especially those with upper lobe involvement, malabsorption, or male infertility. Patients who have laboratory evidence of immunodeficiency should be referred to an immunology specialist for evaluation because test results are often challenging to interpret. Additional specialized testing may also be required to confirm the type of immunodeficiency present and determine treatment options. Primarily ciliary dyskinesia should be considered if adults with bronchiectasis also have chronic sinus disease or otitis media, particularly if problems have persisted since childhood. Bronchiectasis in such patients may have right middle lobe and lingular predominance, and infertility in males or dextrocardia may be present. Nasal or oral exhaled nitric oxide level is frequently low. Definitive diagnosis requires examination of a nasal or a bronchial epithelial sample for abnormal ciliary structure using transmission electron microscopy. The diagnosis of primary ciliary dyskinesia should typically be done in specialized centers because evaluation can be challenging. Non-specific structural defects can be present in up to 10% of cilia in healthy people, and in patients with pulmonary disease, an infection can cause transient dyskinesia. Ciliary ultrastructure may also be normal in some patients with dyskinesia syndromes, requiring further testing to identify abnormal ciliary function. Bronchoscopy is indicated when an anatomic or obstructive lesion is suspected. So, a definition and evaluation of exacerbations. A bronchiectasis exacerbation is defined as a patient with bronchiectasis with deterioration for at least 48 hours in more than 3 of the following symptoms: breathlessness and or exercise intolerance, cough, fatigue and or malaise, hemoptysis, sputum purulence, sputum volume and or consistency. The degree of testing depends on the severity of the clinical presentation. For patients with mild to moderate exacerbations, repeat sputum cultures to confirm the causative organism and sensitivity patterns may be sufficient. These tests help narrow antibiotic coverage and exclude opportunistic pathogens. For more severe patients, complete blood count, chest X-ray, and possibly other tests may be warranted to exclude common complications of serious pulmonary infection, such as lung abscess and emphysema. And don't forget about hemoptysis, as a definition of and evaluation of exacerbations. Hemoptysis. Okay. I suppose that's enough, Yeah. That's enough for first part of bronchiectasis, to be continued, of course. Thanks for your attention. Please don't forget to follow and subscribe us. I don't know where else you can find, where you could find us, for example, in YouTube. If you are in YouTube, put the ring on and subscribe, follow and subscribe. If in podcast, just subscribe. So anyway, don't forget, please, about your donates. Due to these donates, our channel can exist. So thanks for your attention and see you in another lectures. God bless you. Bye.